Top Med Talk.
Hello, I'm Desiree Chappell, and this is Top Med Talk. We are coming to you live from the American Association of Nurse Anesthetists 2019 Annual Congress in Chicago, Illinois. AANA 2019 is a gathering of over 3,000 certified registered nurse anesthetists, or CRNAs, for the largest networking and educational event in nurse anesthesia. Now, this year, the AANA has partnered with Top Med Talk to bring the meeting to our listeners. Over the course of 3 days, we've been sitting down with presenters, AANA leaderships, delegates, to discuss hot topics in the CRNA community and anesthesia practice. Now, I'm joined by my co-host and editor-in-chief, Monty Mythen. Hello, Monty.
Hey, Desiree.
Well, we've been so fortunate to talk about a range of topics, but I think our next guest, we're going to be talking about the opioid crisis here within the U.S., and we have retired Colonel Bruce Shoneyboom, who is a CRNA and Associate Dean for Practice and Innovation and Leadership for Johns Hopkins School of Nursing. Bruce, thank you so much for joining us.
Great. Well, it's great to be here. Thanks for the invitation to talk.
Well, Bruce, first of all, I want to say thank you for your service.
Appreciate that.
That's very important that we do that. Can you give us a little bit about your background and just tell us a little bit about your story?
Well, sure. So I did a 30-year career in the Army, and the majority of that was as a CRNA. The Army has a CRNA program, and so I'm Army trained and did a lot of work in Army hospitals. Then I went to the university as faculty at the Uniformed Services University, and then I deployed for a year in Afghanistan. In my final tour in the Army, I was in command at one of the DoD research labs up at Aberdeen Proving Grounds, where we developed antidotes against chemical weapons.
Oh, wow. Department of Defense, DoD, right?
Yeah. Mm-hmm. Yeah. Yes.
Wow, that's really
Well, it's interesting. You know, my background as a CRNA was a great fit for that role because as anesthetists, we manipulate a lot of the same biological systems that nerve agents affect. And so I kind of understood the science and the biology of chemical weapons and the antidotes developed for them.
Of course, back in the UK, relatively recently, we've been revisiting up close and personal some nerve agent attacks. We've had some assaults that have happened. So we've been revisiting all the biology of that.
Well, while I was in command, I did several trips to the UK with a sister laboratory there. We did a lot of collaboration together.
That's interesting. So right now you're a Dean for Practice, Innovation, and Leadership at Johns Hopkins. What is that title mean?
So, it
sounds really great.
It's a mouthful, right? I was specifically recruited because Johns Hopkins School of Nursing, which is rated the #1 school in the country, does not have a nurse anesthesia program. Oh. And so I was recruited because they wanted one, and the anesthesia department in the hospital was really the main driver. They see that this is a solution to a workforce issue that is problematic not only for the hospital but for the state. And so they felt like this was the right time to build a nurse anesthesia program, and so I'm doing that. And the history there at Hopkins, it's a very long history. They had a hospital-based nurse anesthesia program for decades that closed in the 80s. Part of the reason was the change from hospital-based to university-based programs in the 80s, and so it's taken them a while, but now I'm there building a program. There's other things in my portfolio, but that's the main thing that I'm doing right now.
Wow, that's great.
That's great news, because, I mean, looking at it from overseas, I mean, I've worked in the USA in the past. Looking at it from overseas, where in the United Kingdom, for example, we're just, for the first time, properly embracing non-physician anesthesia providers. There's been a lot of ugliness on the Twitter sphere, about the various different providers apparently seem to fight each other in a way that seems very unhealthy. Whereas this is a very, very positive piece of news whereby, a globally recognized institution is saying, we need more people to help us look after our patients well.
That's exactly right.
And we need to be a part of the education for them.
Well, that's right. And the Hopkins perspective is, we're local, but we're also global. And so, as you mentioned, what other things am I doing? Well, we have a global surgery steering committee that's part of the G4 Alliance, and so I sit on that. And because in the developing world, access to surgical services is far less than the demand, and one of the reasons for that is because of the lack of anesthesia providers. And so we're looking at working in Africa and other parts of the developing world, and how can we leverage that nursing workforce to educate them to be safe, qualified anesthesia providers to increase access to surgical care.
Oh, that's great. Well, Bruce, I know you've also been involved with the AANA in several different levels. Can you just give us a little bit about what you've been doing within the organization?
Sure. So after I retired in 2014, I was recruited to come to the AANA. Originally, I was hired as the Senior Director for Education and Professional Development, and then was promoted to the Chief Learning Officer for the organization. And so during that time, my team and I were responsible for developing continuing education programs to keep CRNAs cutting edge, best practice. And some of the things that we did were a lot of hands-on workshops. Some of them you have seen here at the meeting. Those were some of the things that we did. And the other thing that I think was important as it relates to this topic was we partnered with academia to develop subspecialty fellowships in pain management. We worked with Texas Christian University on a chronic interventional pain management program, which was 1 year of subspecialty education, didactic, and clinical, so that they were eligible to take the NBCRNA non-surgical pain management subspecialty exam. And then we also worked with Middle Tennessee School of Anesthesia, helping them build their curriculum as it relates to acute surgical pain management.
That's great. Well, Bruce, we wanted to talk to you specifically today about the opioid crisis. That's something that we focused in on Top Med Talk and had many conversations about. And I think that you kind of have a unique experience, no, maybe not unique, but pretty unique experience being involved kind of on a national level. So I want to take it back, though, because we have had this discussion, but I think it's important to always kind of reflect back on. Tell us from your perspective and the from the greater perspective, the history kind of how the opioid crisis started here in the U.S.
Yeah, and it is a unique American problem. It was back in the late 1990s where pharma really launched a marketing campaign to help promote opioids and the prescription of opioids for pain management overall. If you look at pain across America, it's estimated that over 50 million Americans suffer from some sort of acute or chronic pain, and it's a huge problem.
So that's, what, about a sixth or a seventh of the population?
Yes.
Like that?
Exactly.
That's right. And it's estimated that we spend almost $500 billion a year addressing this problem. So it's huge. And so there were, and I'm not trying to throw pharma under the bus, and certainly opioids play a legitimate role in pain management. But their marketing campaign was to promote that opioids were really non-toxic compounds, which we really know that they aren't. They're very toxic. And that they were encouraging prescribers to use opioids as a first line of treatment instead of saving them for last measures to treat pain. But that's only one part of the issue. There were other initiatives like the Joint Commission's campaign on pain as the fifth vital sign, and so that was part of accreditation. And hospitals had to track their efforts in assessing pain and managing pain, and those scores were affecting accreditation status. And so there were aggressive efforts in hospitals to also address this problem. And so there were kind of multifactorial drivers that were kind of pushing us to this overprescription of opioids.
And for those folks listening who are not familiar with this environment, we've touched on this on Top Med Talk before, we got to the point whereby we were asking nurses to wake patients up in the middle of the night to ask them if they were in pain.
Exactly.
That's right.
You said, well, I am now.
Yeah.
And if you recorded that, you might get pinged for it, whereas actually they were just sleeping fine.
That's
it really was that crazy, wasn't it?
That's exactly right. So, regulatory efforts and policy efforts, although sometimes good intentions, sometimes have unintended consequences, and that's one.
Yeah, that's definitely a good way to put that. So it's been a problem, and it's only getting worse.
Mm-hmm.
It sounds like,
Mm-hmm.
and I know we've dealt with this. I'm from Louisville, Kentucky,
Mm-hmm.
and the Cincinnati, Ohio, Kentucky,
That's
West
right.
Virginia area.
That's the epicenter.
It really has. Tell us about some recent statistics that we've seen from opioid fatalities.
Mm-hmm. So if you look at overdose deaths, and particularly opioid overdose deaths from the late 1990s to 2016, every year the numbers continued to grow and grow and grow. Mm-hmm. And in 2017, it was estimated that over 47,000 Americans died from an opioid overdose in this country. So that is over 130 deaths a day.
Gosh.
That's like an airplane falling out of the sky every day. And so it was becoming increasingly alarming that we really needed some national effort to try to address this, that local efforts, state efforts were just not enough, that there really needed to be a national effort. And so in 2017, the president declared the opioid crisis a national emergency.
Oh, okay. So that was a national initiative there. So one of the things we had talked about was the CDC opioid prescription guidelines. Mm-hmm. So did that come out of the declaration and then subsequent?
Well, the CDC guidelines were a little bit before that.
Interrupt for 1 second. What's the CDC?
The Center for Disease Control and Prevention.
Got you. Thank you.
Okay. And they are down in Atlanta. And those guidelines came out in 2016, a little bit ahead of the national emergency, but it was still a national effort to try to help inform prescribers about what were safe prescription practices, looking at how do you calculate morphine equivalents, what is an acceptable duration of prescription, how do you monitor patients that are being prescribed opioids. And so this is another example of a very good intended policy that had very drastic unintended consequences. And if I can talk a little bit about those. There were, after those guidelines were released, and they were guidelines, they were like, okay, here's what we think the science is and the best practices are. Policymakers at the state level, facility level, started implementing them as regulatory and creating laws, creating regulations. And what happened was that there's a vast amount of patients in chronic and acute pain who depend on opioids to manage their pain. They've been managed for years on opioids. It's safe for them, and it's the only thing that has worked. And so there's a section of the population that was then either put on forced taper of their opioids, were no longer able to get a prescription for opioids, or their provider said, okay, I'm out. Yeah. I no longer want to be in this space. I'm no longer going to treat patients in acute or chronic pain. And so that was one of the unintended consequences of the CDC safe prescription guidelines.
Well, and I think to take that a step further, I mean, wasn't it in 2017 that we saw some of the highest rates of death? Because, and I've heard it described, and you please correct me if I'm wrong, that once people stopped the having the ability to get their pain pills, basically, their opioid prescribed opioids, they were turning to illegal substances.
That's right. They went to the illegal market to try to get
the pain control, what they were on before. Yeah. And then that's not regulated. And then, recently we've seen in the news and some of the deaths that we were seeing in our region were due to, people using heroin, which we know is very, very unpredictable. But adding fentanyl, which is a common drug that we use in anesthesia every day, fentanyl, Sufenta, and carfentanil, which are hundreds and thousands of times more potent.
That's right. These compounds in the unregulated market, you don't know what you're getting.
Yeah.
And then they're also used in very uncontrolled and unsafe environments. Yeah. And so there was this incredible spike in opioid overdose deaths. And part of that was because of the CDC guidelines limiting access to legitimate sources of opioids, and then them going out into the illegitimate market for those.
So, of course, in healthcare, and it's not just, it's beyond healthcare, but there's always the swing of the pendulum, right? We make kind of reactive decisions, and it sounds like that was maybe one of them. What are some of the recent legislation that's coming out? Are we swinging in a better direction? Are we trying to hit more of a stabilization?
Yes. So in 2016, President Obama signed the Comprehensive Addiction and Recovery Act, and that helped increase access to treatment so that folks who had a substance use disorder could get access to treatment, both at the facility level and then also through efforts like medication-assisted treatment and things like that. And so that was an incredible, important piece of legislation, and part of what that legislation required was for the Health and Human Services to constitute the Pain Management Best Practices Interagency Task Force, which I was a member of.
Okay. And how was that? How were you involved in that organization?
So I got appointed by the Secretary of Health and Human Services to serve on that through a call. HHS, Health and Human Services, put out a call for nominations for folks to be a member of the task force. The American Association of Nurse Anesthetists asked if I would be nominated, and I was the chief learning officer at the time, and as I mentioned, I was involved in all of these efforts related to pain management, and they felt like I could bring those expertise to the table. So they nominated me, and I was fortunate to be selected as a member of the task force. And we worked for over a year, many conference calls, many public hearings on that, and drafting many versions of the report that finally came out. The task force was constituted through both members from Health and Human Services, the Department of Defense, and the Veterans Administration. So that was the interagency piece. But there also were patient advocate groups like the Military Officers Association of America, the U.S. Pain Foundation. They were also at the table. The CDC was at the table, as well as other members from NIH. And then there were professional groups such as the American Association of Nurse Anesthetists. There were dentists, surgeons, psychologists, emergency physicians, all on the panel. Interestingly, although I was nominated by the American Association of Nurse Anesthetists to represent CRNAs, I was the only nurse on the task force, so I felt the larger responsibility to make sure that I was the voice for the 4 million nurses across the United States.
And Bruce, what are some of the key messages that came out of that?
So key messages are in terms of best practice. So first of all, risk assessment is key, meaning that patients need a thorough evaluation before any treatment pain management plan is implemented, that they need to have their pain thoroughly evaluated. The other key messages is that chronic and acute pain is best managed in a multidisciplinary team environment, meaning physicians, nurses, nurse anesthetists, as well as behavioral therapy, massage therapy, that it be besides multidisciplinary, but also multimodal. And so what that does is it brings to bear the therapeutic value of all the approaches while it minimizes the risk associated with a single or monomodal approach to managing pain.
What do you see really coming out of that? Do you see it's created more of a conversation? Do you think anything else, any other organizations or groups will kind of further that discussion?
Well, absolutely. You know, part of our charge is after we've done the work is the dissemination of the work. And so that's one of the reasons I appreciate the opportunity to talk about it, to make sure that the report gets highlighted so that folks understand that the report is out there and that there's some really good recommendations that all providers who manage patients and their pain can use in their own practice. It's really state-of-the-art, best science. We use the best evidence that we could find in identifying where the gaps in care were and how to bridge those gaps.
So if we want to find that, you said this hasn't been published yet?
It's out.
Oh, it is out. Okay, so where's the best place to find this information?
So if you just go to hhs.gov and then in their search engine, just put in Pain Task Force, the report will pop right there for you, and it'll be downloaded in a PDF.
And for team anesthesia providers who are in the operating room, I think the key messages we've been accumulating over the last year or so is, as you said earlier on, opioids are a last resort, not a first resort. That's not a bad way to approach things. A lot of cases you can do without opioids.
That's right.
And then at the end of it, do you really need to send them home with the opioids? Because if they haven't taken any for the last 24 hours, for example, why do they need some to take home?
Right.
And if you are taking some home, think about how much and what.
That's right. Does it really need to be a 30-day prescription?
Exactly. And
yes.
Those are, I think, are simple takeaways we can all challenge ourselves. Now, we don't want to leave people going home in pain.
No.
That's the flip side of it.
That's right.
But they don't necessarily need...
That's right. But we really need to rethink about opioid in our practice today. One of the aha moments for me as an anesthetist was that we had a lengthy discussion about the genetic predisposition of patients to opioid addiction, abuse, and there many times patients are opioid naive. They've never been exposed to opioids in their life, and their first exposure to opioids may be their first time in the operating room. And one of the things we're not asking patients is the question, is there any history of opioid dependency, substance use disorder in your family? Because there may be a genetic predisposition for them. The data is clear that if there is a family history, then the incidence of having an opioid dependence on the other side of their first exposure is higher than somebody who is not. So those are things that, for me and all of us who are evaluating patients for their first anesthetic, or any anesthetic, is asking that question, because then we maybe have an opportunity to redesign the anesthetic that we deliver that either minimizes or eliminates their exposure to these incredibly addictive compounds.
Because the data's clear, I think, from the USA in particular. There's a not inconsiderable number of people who are, as you said, opioid naive, who are subsequently, having been exposed by us to opioids, become addicted.
That's right.
Addicts.
That's right.
Now, you could argue whether we created that addict or not, but it's difficult to see it another way.
Yeah. Well, I think we need to consider that as a possibility. We need to ask the question so that if there is a way, as I mentioned, to minimize or eliminate their exposure, we should do that.
Yeah. At one point that I've had a conversation this weekend, is that, there's a huge movement in anesthesia to do opioid-free or opioid-sparing analgesia for our patients. And what some of the things that are coming out of that is that we may do that intraoperatively, but because we're not having the discussion with the surgeons, or the surgeons are not really buying into it, or that the patient just doesn't understand what that means, that when they go home, they're not extending their multimodal analgesia, and so they actually end up having worse pain and having to go on narcotics and use more narcotics. So we're kind of missing the boat on the education piece there.
That's right.
I think for our patients, as we really get into it and want to do it for our patients, beyond that.
We still practice in silos, and we kind of need to broaden our scope for that, because, if you do a good job in the operating room, but you don't have a good plan on the other side of it, it could all fall apart.
Yeah. And I think that multidisciplinary approach is so
And I know you're talking with Lynn Reed about enhanced recovery, and that is exactly one of the ways that CRNAs can play a role in acute pain management. And the other thing to remember is many of the patients that come in for a surgical procedure that may need their acute pain managed They may also have chronic pain, or they may be patients that have a substance use disorder that may be on medication-assisted treatment, things that have to be explored, and anesthetics then need to be designed to address those co-founding issues.
I actually take care of a lot of those a lot of patients that are in recovery and on alternative meds.
So just a quick shout out for the Perioperative Quality Initiative.
Yes.
Produced a series of papers that have just been published. The front page of the journal Anesthesia and Analgesia, the last one that came out, has a rather sort of disturbing image of a whole load of opioids pouring out of a bottle. And the editorial in there doesn't pull any punches about the contribution we seem to have made as anesthesia providers to this problem, and that we need to do something about it.
Yeah, and there's some good resources.
There's 4 articles in there, and they're open source. The infographics that are within the articles are accessible along with all the other Perioperative Quality Initiative infographics via poqi.org.
Yep. So
That's
be sure
awesome.
to check that out.
Yeah.
So in closing, Bruce, can you tell us what is the AANA doing to really address the opioid crisis?
So I think the AANA is doing a lot. One, in the advocacy piece, they worked hard to make sure that there was a nurse anesthetist on the pain task force, and I think that was huge. Just to highlight, there were 6 anesthesiologists on that task force too. So it was important to have that advocacy voice there. We're doing a lot not only in the federal space, but in state houses as well, to make sure that there are good laws and good regulations on the book. One of the things that's happened is that CRNAs can become certified to prescribe medication-assisted treatment. And so I think that's huge in terms of access. The other barrier to access to care is payment for services. I mean, nobody's going to do this work if you're not going to get paid for it.
Yeah.
And so there really needs to be reimbursement reform. There are treatment modalities that we know that are effective, that insurers and CMS won't pay for. And so there needs to be that conversation of how do we get reimbursement reform so that patients can have access to good treatment modalities, this multimodal approach.
Yeah. Okay. Well, Bruce, thank you so much for sitting down with us and taking the time. It's always an interesting conversation to have about the opioid crisis. I think the more we can highlight it and talk about it, hopefully it'll improve the situation.
Yes. Well, I think CRNAs are well positioned to be part of this solution to this national crisis. And as Randy Morris said, this is an all-hands-on-deck crisis. Everybody should be leveraged to bring their talents to bear to help address it, and I think CRNAs are well positioned to be part of that.
Absolutely. Well, thank you so much.
Yeah, it's
again.
great to be here.
Yeah, look forward to maybe talking to you next year and see your effort, where the efforts are going.
I'll be there. I'd love to talk some more.
Yeah, that'd be great. Well, thanks for listening to Top Med Talk. Be sure to check us out on topmedtalk.com, all your favorite social media platforms. We are wrapping up AANA 2019, but throughout the year, you'll be seeing more coming from the meeting. So thanks so much for joining us and listening. Cheers.
Top Med Talk.
Nick Majerison here. Thanks for listening to Top Med Talk. Now, before we let you go, it's important that we remind you to subscribe to Top Med Talk. That way you'll never, ever miss another episode. Also, if we could encourage you to join us on social media, Twitter, Facebook, LinkedIn, YouTube, pretty much every single social media platform, we're there. Join us. And finally, check out topmedtalk.com. If you go to our website, you can subscribe to email updates. That way we can always tell you where we're going to be, what we're going to be doing, and how you can join us. topmedtalk.com and click on the section marked email updates. Finally, Top Med Talk is proud to act as the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about them as well. ebpom.org is their website. That's ebpom.org. And if you go to ebpom.org/meetings, you can find out about some of the wonderful meetings that we attend and cover across the year here on Top Med Talk. That's ebpom.org/meetings.